Hello, everyone. Welcome to week 4 of HSCI 6240. This week we're focused on quality of care, and obviously, your discussion assignment is focused on providing peer review of three op-eds which I've assigned to you. Take a look at the discussion assignments, discussion forum section, and you'll see that I've written your name as a reviewer and given you three individuals to review. So once they post their op-ed drafts, just go in and review them, and those will, I'm sure, pop up throughout the week. Um, Everyone, please try to submit your op-ed draft by Saturday at midnight in order to give people time to provide peer review feedback and also give you time to take a look at what they're writing and possibly respond to some of their comments. So when you provide peer review this week, make sure you provide constructive feedback and not just high fives for people. And you can one way to do this is just to point out areas of confusion. If you have some references or some ideas for resources they should look at as they work on their paper, offer those. If you have alternative viewpoints, let's say the person is expressing a really liberal point of view and you have a more conservative understanding of the issue that they're addressing, provide that alternative viewpoint and suggest that they consider it. You know, this will be feedback and advice, but the your classmates don't have to take it on, and none of you have to take on the advice that you're given. But I find, and we find as faculty, that peer review, especially online, tends to work quite well. It's a good way for you to interact with one another. It's a good way to um, understand the level at which your peers are performing and the level that they expect you to perform at when you're writing various types of documents, in this case, an op-ed. You can review more than three op-eds if you want to. That's fine with me. You won't be penalized at all for that. If you see something that's really interesting you just want to comment on, feel free. That's what the discussion board is for. All right. Um, you can offer your feedback in the text box, or you can include a Word document where you place track changes in the document and just upload that to the discussion thread for the individual you're responding to. All right, and if you have any questions during the week, feel free to email me as always. All right, this week we're going to talk about quality. I'm just going to talk some about some quality problems and some of the proposed solutions to addressing the quality challenges our nation faces. And I'll talk some about health IT and the Affordable Care Act quality changes too. And I'll talk a little bit about what an ACE is. All right, quality problems. So the problems, the biggest problem that we have is that people are dying unnecessarily because of quality problems. And there are a variety of different types of quality problems. They can be grouped generally into this category of medical errors. There's a report, and you guys have to read the executive summary of the report called "To Err is Human," and indeed, to err is human. Humans do make mistakes. Practitioners do make mistakes. They are not infallible human beings. No one is. So there are going to be mistakes in our healthcare system. We know that, but we are a bit shocked at the magnitude of the mistakes. And as you can see from that document, and if you want to read the entire report, it's there, or browse through certain sections of the report. I suggest you do so, especially if you're really interested in quality or you do work in the quality sector and you have not looked at this report. You really should be aware of it. Because this report and the other one, Crossing the Quality Chasm, really established the foundation for a lot of the innovation that you see going on now uh, in the realm of quality in the country at the federal level and also state levels, and even in individual institutions. These reports were quite important for just incentivizing people to go down more innovative routes for addressing quality issues. So we think too many people are dying from medical errors, and we're really trying to slow down that tide. It's extremely challenging because depending on the type of error you're talking about, you may be trying to address really ingrained problems in a particular healthcare institution that are difficult to change over time. You may be addressing issues that have to do with the competence of not only a few providers, but maybe all the providers or most of the providers in a particular institution. Some institutions perform at a lower quality than others, and there are problems throughout those institutions. So, um, there are no quick fixes for those type of really intense system-wide problems. Uh, they have to be worked on slowly and diligently, and eventually you start to see a change. So this is a really challenging, vexing area for our healthcare system. And given the cost issues that we talked about before, given all the money we spend on healthcare, we'd expect to see a higher level of quality. And we do see high levels of quality in different parts of our system, but we don't see it throughout. And so that's the problem that we face. We lose money on these medical errors, billions of dollars a year. And the errors not only cost individuals and, of course, their friends and family who suffer as a result of this individual also suffering, especially those who die, but we also pay more money. Also, individuals who are not affected by the errors pay more money because as costs go up for addressing these errors, then costs can actually go up for all of us. So because the efforts to try to stop these errors cost money, dealing with these errors may cause additional costs to hospitals that they don't anticipate or providers that they don't anticipate, and may just generally run up the costs of doing business for these institutions, which might push them to do things like increase costs on aspirin, as you read about in the past week. So they may be trying to do things, increase prices on other things in order to make up for some of the other cost problems they have, and this might be one of the many problems that they face, which impact their revenue. All right, the Crossing the Quality Chasm report gives you six things that should exist in a quality healthcare system, and that's that the system should be safe, effective, patient-centered, timely, efficient, and equitable. As most of you know, that's quite comprehensive, but also extremely hard to implement. Right, but what these IOM reports try to do, Institute of Medicine reports try to do, is they try to really give lay out a vision for where we should head as a nation, how we should improve. As some of you know, the Institute of Medicine is sort of a quasi-government organization. They get these almost like edicts. They get requests from Congress to pursue certain issues, and Congress was worried about quality of care back in 2000 when in 2001 when these reports were generated, and so they asked the Institute of Medicine to figure out, well, what is our quality problem, what's going on in the healthcare system, how can we address this problem. So the Institute of Medicine reports will always lay out what the problem is in detail, in extreme detail often, and then they'll offer some solutions. The solutions will follow some greater vision that they have for our healthcare system or whatever issue they're addressing related to healthcare. And the reports they generate are often seen as sort of a guiding light or guiding force for whoever they're talking about. So in this case, for healthcare providers throughout the country, quality is something that the healthcare system controls. The healthcare system can't really control health outcomes, right? So people can do all kinds of things in their life which might impact whether or not they die early or whether or not they are obese or not, and so on. But the healthcare system can control what happens when you come into contact with the healthcare system, right? So if you enter a hospital and you have a problem that the hospital can handle, you should be able to leave that hospital having that problem be addressed adequately and in a safe manner and patient-centered manner and so on, efficiently and equitably, and you should be able to walk out of that system without that problem, right? Or with at least an idea of how, knowing how, at least walk out knowing how the healthcare the hospital, sorry, has addressed the problem, and what else do you need to do to further address that problem with your providers outside of the hospital. So that's sort of the least we can ask of providers, I'd say, is that for people to come in and have problems that the institutions can handle, dealt with, and they walk out feeling like they have those problems taken care of in an efficient manner. And so the Institute of Medicine sort of lays out this challenge, and they lay out recommendations for how we can really get there, because we're not there yet. And these reports were written 13 years ago, 12 or 13 years ago, depending on which one you're talking about. So we still have problems and challenges that we are trying to overcome in the quality arena, as most of you know. So you can see that they laid out this vision which really can guide us probably for another 15 or 20 years before another report is really needed on this issue. Okay, another problem which we're not going to talk about this week is fee for service, because we already covered this. Clearly, this is one of those areas where cost of care starts to affect quality and so on. So we know with fee for service that often physicians get into a situation where they may prescribe too many procedures, or offer too many goods or services to patients. And so they may actually increase costs, may do a lot of things, and those extra things they're doing might pad their wallets, but they may not actually do anything beneficial for a patient. And in fact, they can actually sometimes harm a patient, right? So the more things you do to a patient, the higher the chances are that something might go wrong, right? It's sort of just like fixing your car. The more the mechanic starts tinkering around and messing around with your car, the higher the chance is that something will go wrong. The mechanic will mess up something, right? And many of you have probably experienced that going to the mechanic. So I'd say the same for the human body. As the more you tinker with it, the more you increase your chances of something particularly going wrong. And the fee-for-service system just reinforces that tinkering. Also, another thing we won't spend a lot of time on this week is defensive medicine, but it is something you should know about. So this is essentially doctors ordering tests, procedures, and so on in order to prevent lawsuits. So often when you go to an emergency room, if you have anything that is close to chest pain, they're going to order an EKG and get certain labs and so on to make sure you don't have a heart attack. Why do they do that? When many times it's really just heartburn that you're suffering from, and you may even actually tell them, hey, no, this is just heartburn, or no, I hurt my chest from lifting or something. Well, because the reason they do that is because they're trying to cover their tracks, and they're trying to prevent lawsuits, because they've been burned too many times on people coming in seemingly not having any major problems and complaining of chest pain, and then ending up having a heart attack and dying, and then suing the hospital, right? So in order to prevent that, many emergency rooms, sort of at the drop of a dime, anything that sounds like a heart attack is treated like a heart attack, even if it's nowhere near being an actual heart attack. And with appropriate physical exam, they would not have done those tests. So, ERs are definitely a classic place where providers are trying to avoid lawsuits, and they do a lot of extra things to avoid them. Again, by doing all those things, we run into quality problems. Another issue related to defensive medicine is whether lawsuits actually do anything to improve the quality of care. So if something does happen to someone and they actually are injured in a hospital environment in a negligent way, does a lawsuit actually make the hospital improve? And it turns out that no, hospitals may end up doing more stuff, but they really don't improve their quality unless they really sit down and address, well, what is the root of the problem? Why did this problem occur? How can we educate our staff, or make changes in our operations and so on, so that we actually improve the problem? Just doing stuff to try to ward off lawsuits is not improving the quality of care that's being provided in a hospital environment. So lawsuits can change a little bit about how people act and behave, but there are often underlying issues in these institutions that are not affected by lawsuits, and the temporary fixes that are created for lawsuits often go away over time. So you really need to address greater institutional organizational issues that can improve quality. All right. So quality solutions. There are lots of solutions out there to think about. The IOM Recs have a number of solutions. I suggest you guys read through those, get some sense of what the IOM was thinking back in the late 1990s and early 2000 about how we can improve the quality of care. And you'll see as you look through those things that, oh man, some of these things are actually happening now, and they really are. The IOM is a strong voice for healthcare improvement across the board, and this is no exception to the rule. They really did lay out what should happen, and government responded appropriately, and providers, accrediting organizations, and so on responded to the IOM report. They really do respect the voice of the IOM. The IOM represents some of the most respected members of the healthcare community in a variety of different fields. And so they're really thought of as sort of the elders of medicine, and people respond to what these elders say. So one thing they recommended was a national center focused on patient safety, right? So that this center could really keep track of what was going on, try to coordinate patient safety efforts throughout the country, and that actually exists. There are a number of patient safety organizations that are run by the Agency for Healthcare Research and Quality. That's AHRQ. They're often called ARC in health policy circles. There was an act called the Patient Safety and Quality Improvement Act, which really gave ARC the authority to run these patient safety organizations. You can check out this link to learn more about them. Sorry, I have a spelling error here. The National Quality Forum is an organization that keeps track of and actually makes new quality measures and standards so that, let's say, some hospitals trying to identify quality measures for how they deal with heart attacks that come in through the ER, then the National Quality Forum has usually already has good quality measures in place for things like that, and so that hospital could go to their website to get some sense of what they should be measuring. In some cases, the National Quality Forum's standards are actually incorporated into legislation, so they're mentioned in the Affordable Care Act, and so their standards actually drive some of the incentives that the Department of Health and Human Services is offering to providers to improve quality of care. For example, payment for performance, where providers are given money for meeting certain quality standards. Or they're getting given some incentive money for meeting certain quality standards. The standards came from the National Quality Forum. They spend a tremendous amount of time trying to create standards that are useful and meaningful, things that can actually be measured well by providers. One of the challenges with creating these standards is that providers sometimes provide care in a way that's so focused on the standards, they may actually be missing other aspects of quality, right? So they may treat the standards just like a checklist, and they sort of go down and make sure they're meeting these standards because those standards sometimes are tied to payment, and the institutions they work for will say, hey, you have to meet these standards so that we can get paid a certain amount of money. And so they'll do those things, but then they'll miss other things because they're just so focused on checking off the boxes for what's being called quality. But these standards are not the end all be all for quality care, but they are one way of sort of checking and hopefully improving quality of care by showing providers what standards are out there and what the national standards should be. I'll also say that you probably can't use these standards for a standard of care if you get in a courtroom. So a provider can't say, well, hey, the National Quality Forum indicated that these were the national standards for treating a heart attack, and I followed those, so I treated that person appropriately and there was no malpractice. Yeah, that's probably not going to go over very well. The standards may be useful. Perhaps if you put an expert witness on the stand, they could refer to these standards, but standards alone would not be considered the standard of care for a provider in any particular field. So these standards, while useful, are not the only thing that you look to for standard of care and for quality care. We now have a national quality report. We used to have a national quality and health disparities report. Those two have now been merged so that disparities, racial ethnic disparities, gender disparities, are all looped into the quality report. So now we think of these disparities as a quality issue, and they were always a quality issue. If you're providing, as I said before, if you're providing inequitable care, then you're not really meeting the standard of quality care, right? So if you treat each person who comes in differently based on how they look or their gender or because they're overweight or something like that, then you're not really providing true quality care. You're providing partially quality care. You're providing good care to some people, but not to others, and that's not the kind of care we want to see, especially in a nation that is diverse as ours and is increasingly becoming more and more diverse in pretty much every way you can measure diversity. All right. The IOM also calls for a commitment to HIT and as health information technology. And as all of you know, this is just an ongoing challenge for our healthcare system. There were some stimulus plan dollars that were dedicated to HIT. They provided funding to get providers on board and get them started with setting up electronic health records and electronic medical records, and they're working on that. Right, some providers were already there. Providers like Kaiser have been there for a long time, and frankly, they're looking at other players going, what's taking you guys so long? And I'll talk more about that in a second. But this commitment to HIT is something that we think will definitely improve quality. All right. As I said, these IOM reports lay the groundwork for many of the future changes that we see already occurring today. So, have we made progress? Well, there's a 2010 Office of the Inspector General report in which the Department of Health and Human Services indicates that 134,000 Medicare beneficiaries experience adverse events each month. So that's a lot of people experiencing adverse events. Adverse events include medical errors or all kinds of adverse things that happen. You know, people taking the wrong medication is often a common one. There are things called never events where there are lists of events that really should never happen in healthcare. Sometimes those things do happen, like operating on the wrong limb. If you're supposed to operate on the right leg, you end up operating on the left leg. So things that really shouldn't happen. And I should mention now that I brought up the never events. There's a book called The Checklist Manifesto that might interest some of you. It's by a scholar named Atul Gawande. He wrote the Cost Conundrum article, which I suggested that you read last week. And this is a really interesting work. The Checklist Manifesto is the name of it again. It's a really interesting book, and it really just talks about this idea that in surgery and in other aspects of healthcare, if you have a checklist, you can actually cut down on medical errors. This is particularly useful in surgery because there's just so much going on. There's so many things that need to be checked, and many surgeries have been done for decades, and so uh, practitioners know what they should be doing, but sometimes they miss something. So they may miss one or two things while they're doing the surgery. They may sort of forget, well, to count the cloths that they left in the patient, or they may forget to look around for certain instruments. And so if you just have a checklist there to go through all the things that should have been done during that surgery, at the beginning, middle, perhaps, and definitely at the end, then many times you can avoid unnecessary medical errors just by having a checklist. And it actually works. It actually improves quality of care. Now, as you can imagine, a lot of providers don't want checklists. They think it simplifies what they do too much. But in fact, basic checklists actually work quite well. So sometimes simple solutions are very useful and very important, and sometimes they're overlooked because they seem so simple, yet in application they're very effective. So just having a checklist can go a long way. All right, some more recent solutions. Just building a little more on this health information technology. Uh, the Kaiser reading you have on this is, I think, very useful. It does a good job of just covering all the key issues in this area. So the goal is to have computerized health records throughout the nation, right? So we want we want records that offer an interface for patients, providers, and institutions, right? So that means, if a patient goes to a computer or if they use their smartphone, we want them to be able to access their medical records. And we want the interface to be easy for them to read, very patient friendly, patient centered, right? As the Crossing the Quality Chasm pointed out, let's make quality care patient centered, right? So let's make something user friendly, something Steve Jobs would be proud of, right? Um, then something providers can use. So again, making it user friendly for providers, a system that providers can go to and find everything they want, a system that talks to providers and helps them make decisions. There's really just too much information being developed these days for providers to keep up with, in order for any provider to truly keep up with well. So we need info systems in place to help providers learn when new information exists that is important and that's relevant to the work that they do. So for one thing, one example is adverse reactions to not sorry adverse drug interactions, right? So often uh, experiments will be done to show that two drugs interact in a way that might potentially lead to some adverse event for patients. Well, no provider can keep up with all the studies that are coming out on drug interactions or new discoveries and so on. So if you have an electronic health record that functions really well and it is user friendly for providers, when they write down the drugs that they think a patient should take, something should pop up to say, well, hi, hello provider, the two drugs you've just listed here are likely to cause problems in patients that are of the age and certain symptoms and so on, that have the certain characteristics of the patient that you're prescribing these drugs for, right? So we want those kind of decision aids, those kind of clinical decision support tools to be integrated into records so that they can actually help improve quality, right? Because otherwise, if the provider didn't know that and they gave the two drugs and the adverse reaction occurred, simply because they were not aware of it, then again, they are human. They do make mistakes. They can't know everything. So the problem would occur is the patient might end up in the hospital unnecessarily because we could have prevented that because the information was out there. But the problem is that we didn't have a system that gets the information to the provider. So not enough providers have those kind of computerized systems that they work with now. So errors happen all the time that could have been prevented with appropriate info systems, right? Now, you can imagine creating systems like that, especially systems that are smart and that adapt over time to new research information that comes out, things that really do touch providers and are meaningful for providers. Creating systems like that are quite difficult, right? And depending on the specialty that you're focused on, the provider is going to want to see more or less of certain aspects of a patient. Some providers are going to want to see images, right? So images take up a lot of memory. Some providers need video because they may be looking at something that is essentially a video file for a particular patient. And so there's a lot of considerations here. It's a tremendous amount of information that needs to be provided in a way that is very useful and friendly to the different types of users. Then we need records that institutions can exchange. So, whether I'm at Kaiser or I'm at GW Hospital, my record should be able to float around and follow me. It should be portable, right? Well, that turns out to be one of the biggest challenges. A lot of it has to do with competition. So, if you have one provider using company A for their medical records and the other provider is using company B, sometimes company A and B are competing so harshly that they don't want to come up with ways for their records to work well with each other, right? And so that's where the government comes in and tries to lay down some basic framework for how these records should be created and established and how they should operate with one another. That just remains to be a challenge. So the the competitive factors that exist within our capitalist system are really causing a lot of difficulties and are posing a lot of barriers and challenges, as they should in some ways, when it comes to any kind of new innovation and so on, because there's a lot of opportunity here, there's a lot of money to be made. Some of the countries and some of the world's biggest companies are interested in health information technology, and all that it can do for their companies and profit margin and so on. So it makes sense that competition is getting in the way a bit here, but at some point, if we are going to have products that make sense, the competitors really have to learn how to work together, and so they have to really learn how to work with government, with each other, to get to a point where we have these systems in place that are working well, that can be used in an interoperable way throughout the country. Now, if you look at a system like the VA, this already happens. So the VA already has a national health care record. Well, and you might ask, well, how can the VA do it? And many of you, like me, grew up thinking of the VA as a sort of a second-class healthcare system. Well, the reason the VA can do it and the rest of the U.S. has trouble doing it, except for Kaiser, as I say, because they also have something similar to the VA, is that the VA really has sort of a command and control system. They operate and in a way that's very similar to how the military generally operates, in that the VA says, hey, VA system, we're going to do X, and everyone has to do it, right? Well, that just doesn't exist for the rest of the healthcare system in this country. We have a much more fractured, fragmented system. Just imagine, we still have solo providers out there who are not attached to anyone. They're out there by themselves. They may have hospital privileges somewhere, or they may not. But they're out there, especially rural providers, out there just kind of doing their own thing. And who's going to link them to some kind of electronic record system, especially if they're an older provider, that makes sense for them, that's affordable for them, that's going to somehow be interoperable with other systems that are out there. Now, there are solutions, there are good IT solutions for a person like that, but implementing it, getting them incentivized to do it, and you can't force them to do it, is a challenge, right? Now we think that moving forward, Medicare is going to start requiring providers to have health IT systems in place. So perhaps what you might see is some providers who are really opposed to it may simply just not see Medicare patients, or they may just get out of business. Many of those providers are older providers, and they probably are going to be trending out anyway. I think most younger providers really do want computerized records, which is a good thing for all of us who will be patients, and all of us will be patients one day. So it's good that younger providers are on board with this, and that they want it to work, and they want to see it work well, because they have high expectations for what technology can do, because they've seen technology do quite a bit throughout their lifetimes, and they've seen it improve. Young providers would not mind having electronic medical records or having electronic, yes, that's right, medical records sitting in their hand, that they can look at when they're on the beach, or anywhere. They would not mind doing that, whereas older providers just probably wouldn't be interested in that approach. And that's a pretty gross average stereotype of older providers, I know, for any older people listening. But that's sort of the general approach. The younger generation is really going to push this and really make sure that this actually happens over time. As you saw from the reading, or as you will see from the reading, getting the benefits from HIT is probably going to take some time. Probably going to take a few years before we really see true benefits from HIT, before we really see it influencing quality of care throughout our system nationally. The VA, on the other hand, has seen benefits already. They've seen it impact various aspects of care, lower medical errors, and so on, in a way that the rest of the healthcare system will not see, because it just takes so much time for us to make this, for HIT to become used nationally in a way that functions well and makes sense. And it's just going to take time before we really see benefits throughout the healthcare system in our nation. All right, now the Affordable Care Act. has a few features to it that impact quality that I want to mention. It does quite a bit with regards to quality, but I'm going to only point out a few things here. So one is that he establishes a national quality strategy. Again, this is sort of building on the work of the IOM. So the IOM already laid the foundation, and this is sort of one of the many pieces of the house that's being built on top of the IOM foundation. You could go to healthcare.gov to learn more about the strategy. All right. Um, Another thing that the Affordable Care Act is doing is decreasing money that goes to hospitals when they have unnecessary hospital readmissions. So, what is a hospital readmission? So, this is when you go into the hospital, you're treated for something. Let's say you're a diabetic, and you go in and you're treated for some complication related to your diabetes. You think the problem is taken care of, but the hospital forgets to do something. But instead of them taking care of that problem in the hospital, they discharge you and they send you home. 1 week later, you have a problem related to what they forgot to do. You end up back in the hospital or back in the emergency room with the exact same issue, the same problem that they overlooked when you were there in the hospital, or they just forgot to manage well when you're in the hospital. So Medicare doesn't like paying for that, right? Medicare doesn't like seeing people go into the hospital 1 week, stay out for a week, and come right back. To Medicare, that seems to make no sense, right? They think that hospitals can do a better job at preventing these type of readmissions. Now, not everything falls into hospital readmissions that Medicare is concerned about. There are only a few categories of illnesses that Medicare is focused on right now, but you're likely to see this grow over time. The more Medicare learns which hospital readmissions should not occur, the more you're likely you are to see Medicare tie it to payment. So right now, when a hospital readmits someone for heart attack is one of those things. If it's not managed well, then the hospital will receive less Medicare reimbursement for the second time that the person comes into the hospital for something they should have been treated for well before. Now, the problem with that is one problem is that sometimes people do have new problems that look like the old problems, right? So sometimes people are just complex patients, and so they have a couple of heart attacks in a month. So they go home and they keep eating the same diet, no changes are made. Maybe they take some of their medications, not all of them, and they come right back. So now, should the hospital be punished because the patient is not managing themselves well and not doing what the hospital told them to do? That's the question, right? Medicare is sort of saying, hey, hospital, you got to figure it out. You got to find a way to push that person to do a better job of managing themselves, or you got to get other providers involved in a way that will prevent them from coming right back to the hospital, right? This is also a problem for lower quality hospitals, right? As I said before, not all hospitals perform at a high level. So if you're a lower quality hospital and those hospitals tend to have less money, and so now, if you have this readmission problem, you're going to get even less money from Medicare, which means what? Which means you are really in a bad situation. So you're already a low quality hospital. You get less money for the care you're providing. So you already have a low profit margin to begin with. It becomes even lower because Medicare is giving you less money. Then you've got a huge problem, right? Those hospitals are going to have a hard time surviving. On one hand, that may seem good to you. You may say, well, lower quality hospitals need to go away, right? On the other hand, some of those low quality hospitals are the only source of care that some people have in a region, in a large region, maybe a region with multiple counties. Maybe a quarter of a state in some cases, right? For more rural states. So you have to think about, well, what does this actually mean? There are some hospitals out there that just nationally are not doing well, but they are they play an important, essential role in communities. So you have to be careful about these kind of policies that are sticks instead of carrots. So a stick incentive means that you punish someone for doing something, for engaging in a certain behavior. A carrot means that you reward people for behavior, right? Carrots are often better because carrots you can do without carrots. So Meanwhile, a stick harms you in some way, right? So if you reward an institution for meeting a certain standard, so that they perhaps lower their hospital readmissions and they get a bonus payment from Medicare because of the savings they provide in Medicare, well, that's a good thing. But if you and if they don't do it, then they wouldn't be punished anyway, right? But on the other hand, if you punish them, you have this stick incentive, and that's what we're doing. Then what you're going to do is harm them even more than they're already hurting, right? So they're already limping along, and then you come along and hit them again, right? So that they fall down to the ground. Instead of saying, "Well, I know you're limping, but I think you can do better. So I'm not going to harm you in any way. But if you do improve, I'm going to actually give you something, right? A better pair of shoes or whatever it is you need to stop you from limping, right? So just think about that. Stick versus carrots. Carrots tend to work better. Horses run after the carrots. They also run when you hit them with a stick, but a carrot is a friendlier way to go, right? So accountable care organizations. Accountable care organizations, first of all, are not just one thing. So there's no such thing as the accountable care organization. There are multiple accountable care organizations. There are all kinds of things that people can do. This is just a big name, a heading for something in the Affordable Care Act that is meant to stimulate innovation among healthcare providers of all types, right? So for providers receiving Medicare, they can come up with different healthcare delivery approaches that improve the quality of care that people receive and also save money. So the idea is that when they save money, so does Medicare, right? And Medicare is willing to give them some of the savings, some of that extra money that they put back into the government's pocket. The government wants to share some with them. So that's the incentive. That's a carrot incentive, right? And not a stick. So you don't have to do this. No provider is being forced to form an accountable care organization. But it turns out that a lot of providers have ideas and they want to innovate. And this is really physicians, really not just physicians, but health professionals, health providers really pushing the bar raising the bar themselves, right? So providers are being offered money to show Medicare what they can do to improve the quality of care. This is better than a fee for service system. It's not the end all be all. As you can see from your rating, there are problems with it. Not every provider out there is likely to benefit or even be interested in forming an accountable care organization. Providers are not being forced to create them. There's just money being offered, money on the table, if providers can come up with clever ways to save money. Right now, this seems to be working best for institutions that are already doing it. So it's really just giving institutions money who are already saving money. It doesn't seem to be attracting a lot of institutions that have not done this before, and definitely not attracting some of the lower quality institutions, which is really what you'd like to see. But perhaps over time, as the Accountable Care Act, the Affordable Care Act stimulates more ACOs, more accountable care organizations, then perhaps we're likely to see lower quality institutions get on board and try some of these things too. All right. And I just want to say that the challenge will continue. Quality is a really a difficult, complex issue to address. One issue that we're not going to talk about much in the course is fraud and abuse. Congress recently proposed, I think there's an article out yesterday on Congress making a proposal to decrease fraud and abuse in Medicare, and it's actually a bipartisan proposal. So we may actually see some action on that issue. I think with all the corruption that's going on, especially at the state level, and certain states have really been bad at this, like Florida, that members of Congress on both sides of the aisle really want to crack down even more on the corruption in this area. And this is one easy way to cut down on costs, but also to decrease some quality problems that are related to fraud and abuse also. So overuse, unnecessary testing, and so on. And in some cases, coming up with fake patients and just doing all kinds of things that really distract from actually what providers should be doing. And these are things we want to root out of our system so that we have a quality system that's efficient, effective and so on. So uh, as you consider some of these questions. How can quality be defined? It's not easy to define. There are lots of different definitions out there. You should think yourselves about what quality care means to you. What do you think it means based on the reading? How should it be measured? What are objective and subjective ways of doing that? What are some of the quality problems that exist where you are? Think about that. What are some ways to improve the quality of healthcare settings where you work or places that perhaps you plan to work in the future? And also maybe institutions that you interact with as a patient. What are some of the ways that quality can be improved? So think about some of those things as you do the reading. Thank you. This was a bit longer than I initially planned, but there was a number of comments I wanted to make on quality issues as I went through the slides here. So, as always, ask me any questions you have, and I look forward to seeing your peer review feedback on Blackboard. Take care. Bye.